So, how are you, everybody? I understand that all of you are planning for part 3 exam in this year, whatever in May or even in November. Thanks so much for attending and accepting the invitation to attend this meeting today. I am Dr. Osama I am MRCOG and I am consultant gyne. I am working currently in Egypt and I worked before in UK in St. Mary Hospital, very lovely place. I am interested more in subfertility and endoscopy. I have diploma in each one of them. Plus, I have diploma from Harvard in UK, in America, sorry, for teaching. And I have diploma in subfertility management from Birmingham University in UK. So congratulations for passing Part 2 exam. You passed the most difficult and most tricky step to become member of the Royal College. And we assume after passing Part 2 exams that you have good amount of knowledge, which will help you so much in passing Part 3 exam. I used to hear this sentence before my exam in Part 3, but I didn't believe it at this time. Okay, but you have to believe in your knowledge. And don't worry, in Part 3 preparation, I will assume that you missed some parts, so I compensate any loss. Don't worry about this point. Also, always you hear from the college, we are not assessing your knowledge because already you passed part 2. Okay, but I know the fact. Okay, that we forget. And some doctors that can pass part 2, even if studying was not 100% perfect. We can compensate these points. Okay, but at any way, you passed already the most difficult part, which is part 2. Alhamdulillah. Welcome. And then now you are preparing for part 3, which will be the most interesting one in studying because it's concentrating upon the practical aspect and concentrating upon skills that you should be using already every day in your everyday practice. Whenever you are going to the clinic, whatever private or governmental or general hospital, these skills, these are the ones you are going to use in passing part 3 exam. There is a challenge here that sometimes some doctors working outside UK, they are not fully aware about the UK practice and these skills they are going to use in the exam. Don't worry, we are here to tell you about what is happening in UK and you will be trained all over this course to do same like what UK doctors do. Because already in the exam you are in competition with candidates all over the world, including UK candidates. Of course, this point is very easy for UK candidates. For overseas candidates, the challenge with the skills. For UK candidates, the challenge with the knowledge. UK candidates, they don't have good time to study. You are having good time for study more than them. So UK candidates, the problem in the knowledge, overseas candidates, the problem in the skills. Everything will be discussed. And passing MRCOG exam itself, it's a routine step for every trainee. So what is your level now? Your level as if you are ST5 and you want to become ST6. So competent ST5 should be somebody who passed part 1 already. That's why he became ST3 before. And then now he passed part 2 and part 3 and trying now to be ST6. You know the training matrix. An ST5 to become ST6, he should pass part 2 and also part 3 exam. That's why any ST6, or let's say most of them, most of ST6 already they passed part 2 and part 3 MRCOG exam. That's why the exam is assessing you at the level of ST5. And this is an important problem. Some doctors in part 3 exam, they behave as if they are the consultants. Okay, so don't forget, you are at the level of ST5. I remember even in my interview, before I have a job in UK, I had an interview with the clinical lead. And the clinical lead asked me, what is your level of competences? I said, I can do so, I can do so, I can do so many things. He tell me, so what the consultant will do? You are having all of these competences. So there is a problem in this exam. If you are underqualified or even overqualified, be careful. You have to deal in this exam as if you are an ST5, under cover of the consultants. I understand that ST5 after just 2 years or a little bit more will be a consultant, but you are not a consultant yet. Don't behave in this exam as if you are the consultant. You are not. You are an ST5. So, throughout the practice for the exam, you are an ST5. Not the most clever one and not the most junior one. You are in between, but more towards being a senior one. ST5 is a registrar, and the next year will be senior registrar. ST6 is senior registrar. So, passing in part 3 will depend upon the huge base you made in part 1 and part 2. So we need just to learn the skills which are important for part 3. Skills including taking history, communication with the patient, communication with colleagues, and to be a safe doctor, which is a very important domain. So this exam needs hard working, yes, but let me remind you, it's more interesting than studying for part 2. In part 2, let's say it frankly, we were very aggressive in assessing part 2 in the knowledge. Yes, we were very aggressive. And we need even the very minute, small parts of knowledge. We need you to be aware about them. That's why passing part 2 is something very good. You are considered somebody with very good knowledge. Okay, but assessment is not with the same difficulty in part 3. In part 3, we need other things like safety, communication, and other skills. So, the good things in studying for part 3 that this is the usual daily work skills. With every patient, you take history, you communicate with the patient, and even communicate with other colleagues, and you use your applied knowledge. So this is the usual daily work. And they are techniques you need to learn. Already you have the knowledge, just you need to build some techniques. Personal skills, whatever in dealing with the patient and also in dealing with colleagues. Because in exams, you will be asked to teach a colleague something or to deal with a patient. And already you passed knowledge. You will use this knowledge to pass the exam, inshallah. Okay, and I understand some doctors passed part 2 maybe 1 or 2 years or even more. Don't worry, we will compensate this. So while studying, whenever there is a station including knowledge, I will tell you what is the most update information about this topic. So it's not without difficulties. There are some difficulties. For example, the cost. The exam is more expensive than part 2 exam. And unfortunately, the cost of the exam increased one more step in the last few months. It increased 40 sterling pounds more. I will show you now the price list. And only you have 4 trials. Part 2, you had unlimited number of trials as long as you are not a trainee. But in part 3, you have only 4 trials. Unfortunately, if somebody couldn't pass part 3 in these 4 trials, he will go again to study part 2 exam. He will have part 2 exam again. This is a challenging point. And I know some doctors who reach to the trial number 4. I don't know somebody yet who didn't pass in the 4 trials and went again for part 2. But I know multiple doctors who passed from the trial number 4. And even I helped some of them. They came to me in this 4th trial and they had my course. Alhamdulillah, they passed. Number 3, Psychological load. Actually, this is coming from the point number 2, from being only 4 trials. And language. That's why some doctors, I may ask them to have some sessions in English language. Some doctors actually they have language that when they speak, they can give false meaning. Okay, so you can have misunderstanding from this language. This is not a language exam. This is clear. But we need un your English to be understandable. Okay, so what you say, I understand. Not a matter at all. What is the accent of your English? It doesn't matter. It doesn't matter. You know, even doctors in UK, many of them Indian, Egyptian, Pakistani. So it doesn't matter the accent. We don't want the British accent. Already, mostly, most of you going to have the exam outside UK. So the accent itself, it doesn't matter. Okay, but we need your English to be easily understandable. So this is May timetable, May exam. The dead time to confirm that you wrote exactly your home address in your MRCOG account. So please, everyone today, as long as you are planning for Part 3 exam, whatever in May or even later, go to your MRCOG account. In your details, write your address. We need the address in the country where you are going to have the exam. If you write that your address in Egypt, we understand you are going to have the exam in Egypt. If you write in Saudi Arabia, we understand you will have the exam in Saudi Arabia. So today, go to MRCOG account and update your address. Maximum or deadline is 26th of January. Do it today. Don't wait. And the last time to submit assessment of training. Also try to do it today. It's easy. And I will send you on the group a video about how to do the assessment of training. Assessment of training, it needs that you send the performer confirming that you had 4 years of training in gynae and ops. Some doctors already made this assessment of training before, even before Part 2 exam. Okay, don't do it again. If you did it once, it's enough. You don't need to repeat it. Just once in life. Okay, it's enough. Then booking for the exam will be in February. And the booking will close 2nd of March. Although these are 6 days, but most of seats will be occupied in the first minute. In the first minute, actually, you will be sitting in front of your computer. And whenever the clock comes to the booking window, for example, it became 9 a.m., you will press the link. You will open the page containing the locations of the exam and how many seats are available. You will find already many seats are already occupied, although you pressed in the first second. So some doctors were faster than you. Don't worry, we have an engineer who can book the exam for you if you want. And second booking window, because the first booking window mainly for the UK trainees. Second booking window, 5th of March until 9th of March. But as we said, book the exam in the first second, maximum in the first minute. So you have from a second to a moment, not more. If you can do within less, okay, that's better, within less than a second, but not more than a moment, not more than a minute. So you can choose a place that you want. Because if you didn't find a seat in the country you want, you will have to choose a seat in another country. So you will need to travel. And better not to travel before this exam. Exam date will be 6th, 7th, and 11th, 12th of May, inshallah. So this is a timetable of May exam. And this is a timetable for November exam. So almost everything is the same, but 6 months after. For example, deadline for confirming the home address, 20th of July. Assessment of training, 16th of July. As we said, do it now. Today, do it. And November exam will be in the end of October and the beginning of November. Always a result about 1 month after the exam. And this month always is considered a stressful one. I advise in this month, forget everything about the exam, make a journey, make a picnic, forget it already. The result of the exam is written before you were born. So don't care about it. Fees of the exam. It increased. For example, look at band A, 947. Here, band A, 994. So increased about 40 to 50 pounds. The same in band B, 883, it became 927. Increased about 40 pounds. The same for band C, 648, 680. So also increased about 30 to 40 pounds in each band. If you are in UK, it also increased, but still the lowest one. 591 became 620. Increased also, but still the lowest one. It doesn't mean that I'm not advising you to go and have the exam in UK. If you are having the exam in UK, it means you are having the exam among the UK candidates. They should have already good level of performance. If you already go, I passed my exam in London Center when the college was in front of Regent's Park in 2019. After that, they moved to Union Street. Okay, this is November 25. This was a previous one, so you don't need it. So either May or November. So how the exam looks like? Exam now is physical, not online. It was online during the COVID pandemic, but now it's only physical. So exam is made of 14 stations. Every station made of 12 minutes. These 12 minutes, 2 minutes of them you are reading the question, and 10 minutes you are performing. So overall, it's 168 minutes, continuous, non-stop, non-stop. So there is no time to go to the bathroom. You should go to the bathroom before the exam starts. So this is called circuit. And each circuit has 14 candidates because we have 14 cubicle, 14 stations. For example, a candidate will know that he will start with station number 5. Okay, he will go and stand here when the exam starts. Another doctor knows that he will start with station number 4. He will go and stand here. Okay, so after standing, when it's the due time for the exam to start, they will give you alarm that you can now turn and start reading the question. This is a question. Some questions made of one paper, others can be made of 2, 3, 4, or even 5 papers. So you need to read fast and collect what are the most important points. They provide you before the exam with a pen and a paper, so you can write something. For example, I recommend that you write the name of the patient and you write some important keywords that you think they are important to be said in this station. Okay, after 2 minutes of reading, you will hear a ring that you will enter inside the cubicle. You will stay there 10 minutes. What you will find inside? You will find people sitting and there is laptop in front of them and somebody without laptop. Or you can find only a person with laptop. So either the possibilities are, so let's make it. So what you may find inside. The lowest number that you can find, one person with laptop. So this station already structured discussion. You will know before you enter inside the cubicle that it's a standard structured discussion because it's written on the exam paper that this is a structured discussion station. So inside you will find examiner. There is computer in front of him. When you enter, you say, "Hi, sir, I am ready." Don't say your name, please. Don't say your name. Just, "Hi, sir, I am ready." And either you can start speaking because already you know what you need to speak about, or you are expecting the examiner to give you some questions. Or you can find two persons inside, two persons, one with PC and one without. So this is simulated task, whatever simulated patient task or simulated colleague task. The one with computer, this is the examiner. The one without, this is the role player. So you will start to speak directly with the role player. Forget everything about the examiner. Don't care for the examiner at all in simulated tasks. You will just interact with the role player. Forget the examiner at all. Or you can find three persons present inside. You can find two with computer and one without PC. So who are these two people? Two examiners. One of them called clinical examiner and the other called lay examiner. Clinical examiner is a gynecologist. He will assess knowledge, safety, communication, information gathering. Lay examiner is not a doctor. He is coming just to assess your communication and dealing with the patient. They don't know gynae and obs. They are just coming to assess your communication, empathy, support, asking the patient good questions or not, using lay language or using difficult medical terms, which can be difficult for the role player to understand. That's why lay examiner stations are tricky. In the exams, there are 5 stations containing lay examiner. And I consider stations containing lay examiner as if they are double station. Why double? You will be assessed twice. You will be assessed by 2 people. Every one of them will give you mark. If we say that in every one of the 14 stations, you will be assessed in all of them by a clinical examiner, clinical examiner will give you a mark out of 8. So clinical examiners all over the exam will give you mark total out of 112, 14 in 8. 5 stations, they have lay examiners. Lay examiner will give you mark out of 6. So 5 multiplied by 6, 30 marks with the lay examiner. Overall, it's 142. So lay examiners are very important. So in stations containing lay examiner, be very careful about your language. Be very supportive and empathetic with the patient. Avoid using any jargons. And of course, avoid using Arabic words. It happens, even in the exam. Salaam alaikum. يعني. Inshallah. We hear these words in the exam. So be careful. So throughout the training, okay, you will be informed about these mistakes. Okay. So 14 stations, everyone 12 minutes, total 168 minutes without any breaks. So, for example, but now, of course, we are using computers. So people with computers, they are examiners. You will interact with a person without PC. Can there be 2 role players? Yes, this is infrequent, but it can happen. For example, female and male partner. coming for fertility clinic, or even two females seeking for pregnancy. Okay, they need a semen donor and asking for one of them to be pregnant. Okay, but most common that there is one role player. So, information gathering. What we need to be aware about. We need to explain the purpose of consultation. For example, you will tell the patient, I know that you are here to discuss the result of the scan. So this is the purpose of consultation. It will show even that you have good situation awareness, clear history taking, and this is very important. And please ask only relevant questions. It should be focused and relevant. What is the meaning of relevant? Ask about what is useful in this situation. Don't ask about what is not useful. I will give you an example. If a patient coming to be counseled about the result of the scan, and the scan unfortunately showing intrauterine fetal death. In this station, if you ask irrelevant questions, the patient can be very angry with you. I am coming and you are telling me my baby died and you are asking me irrelevant questions. For example, if the candidate asked here, uh, did you take any contraception before? Is it relevant? Why it's relevant? It's not relevant. It's not related at all. It will be a waste of time for you, and even it will annoy the patients. Okay? So be careful. Don't ask any irrelevant questions. And already the college is telling examiners, if the candidate asked irrelevant questions, please downmark the candidate. That's why throughout preparing for the exam, whenever there is a question, I think it's not relevant, I will ask you why you asked this question. If it's not relevant, you will be downmarked. Okay. Use structured approach. So already there should be a list of questions you need to ask in your question, in your mind. And for every case, for every station, you will think, which one here useful? So I will say it. Which one not useful? So I will not say it. And you should always be able to use closed questions and open questions. And always start with open questions. For example, can you tell me more about your symptoms? I like this question. Can you tell me more? Can you tell me more about your symptoms? Okay. Did you have any medical history before? Yes. Can you tell me more about them? Can you tell me more is a very good open question. Okay. And it will help the patient to say everything she was instructed to say. But let's assume that you started with a closed question. For example, I know that you have pain. For how long this pain is present? In which site the pain is present? What increases this pain? What decreases this pain? Is it referred to a specific site? Actually, if you tell her, can you tell me more about your pain? She will say everything without wasting your time by asking multiple questions. But if you ask an open question and you didn't get your target, okay, you can ask specific focused question, even closed one. Okay, but always start with open questions. Demonstrate empathy. Very, very important. Many candidates may not pass in this exam because of empathy. And the problem is, every one of us feels that he is very empathetic. Okay. And you will know the truth when you are assessed by somebody. You think and you thought you were very empathetic while you were not. You will say, I felt inside. It didn't appear in your language, in your speaking, and even in your facial expressions. Okay, that's why it's very important to be empathetic and to be trained how to be empathetic. We saw even in the exam, okay, that the role player is saying, my life is destroyed. My partner is going to leave me. My life is destroyed. And the candidate will say, okay, do you smoke or drink alcohol? He didn't give any reaction to these very dramatic, very tragic words the role player said. That's why you have to react to what the patient says, and you should be empathetic whenever there is indication to be sympathetic. And no need to be over empathetic. Okay, just empathy when needed. So a patient coming with polycystic ovary syndrome, no need for empathy. But a patient with recurrent miscarriage, yes, this needs empathy. A patient with domestic violence, she needs empathy. IOFD, she needs empathy. Okay, hypertension with pregnancy, no need to be empathetic. Okay, okay. Always confirm that the patient understands what you say. But don't tell her, do you understand me? Because if you say, do you understand me? And she said no, it means she's stupid. Okay? But ask by saying, am I clear so far? So if she said no, so I didn't understand well. Okay? So always say, am I clear so far? And in every station that there is a role player, you have to ask at least once, am I clear so far? Okay. Integrate all available clinical evidence. Okay, so good clinical knowledge will help you to choose the good questions and also to tell the patient the good options. This is more actually in applied knowledge and safety. So this is information gathering. Anyone has any question, you can open your mic if you want to ask about information gathering domain. It's okay? Okay, next domain. Because in the exam, we have 5 domains. In every station, there will be 4 domains involved in this station. We will take everyone as separate, then we again collect how we are assessed. So this is information gathering. Next one, patient safety. And actually, patient safety is the most important one. Most important one. And even patient safety can be depending upon other domains. So if you cannot take good history taking, safety will be compromised. If you cannot give good options for management, safety will be compromised. If you cannot ask about good investigations, safety will be compromised. Okay, let's start safety. Risks and benefits in a balanced way are very important. Notice that the patient is the one who will choose which line of management will be used. Your role as a doctor is to tell benefits and risks and tell the evidence about every one of them. For example, a patient with ectopic and beta HCG more than 5,000. I will tell her management of ectopic can be expectant, medical, surgical. I will explain everyone, but I will tell her with this level of pregnancy hormone, using expectant management will be not the safest one. Okay, and even medical with methotrexate. The risk of failure here is high. That's why it's better to be surgical management. The patient is the one who will choose at the end. You said the evidence about every one of them and the risk of success, risk of chance of success and the risk of failure in everyone. Support informed decision making. Again, the patient is the one who will choose. You will provide her with the evidence and with options, and she is the one who will choose. And always avoid to give one option. So don't say pregnancy hormone 5,000, okay, management only surgical. So how she can make a choice? Give her options, explain benefits and risks in everyone, so she can choose. Autonomy. one of the pillars of ethics. The patient is the one who should make the decision, not you. Demonstrate flexibility. So don't say this is the only option suitable for you. Any other option is not good and you have to choose it. No, you should be flexible. For example, a patient asking for home delivery and she had specific risks or specific complications in the previous delivery. She doesn't want hospital. She doesn't want midwifery care. Okay, you have to be flexible. You have to counsel her and negotiate how we can make the home safer. For example, there can be an ambulance available nearby, okay, and uh, she should understand whenever there are complications, we will need to transfer to either midwifery or better to be obstetric lead unit. So be flexible. Don't be very rigid in one option only. Reassure patient that nothing will happen without her consent. For example, IOPD and the post-mortem examination. Nothing will be done without your consent. Summarize discussion. If there is time, actually, sometimes in the exam, there can be not enough time. But if there is time, summarize what you said. So let's summarize again. The condition you have is called so and so. The management can be so and so. And I will give you patient information leaflet and you need to make your mind as soon as possible. Show understanding, safety process, and wider population. Okay, we need more the management to be focused. Advantage and disadvantage of management. You have to explain. That's why she will be able to make an informed decision. Importance of clear written information, like patient information leaflet. And unfortunately, not all conditions, they have patient information leaflets. The rare conditions, they don't have. So you have to provide patient information leaflet for the common problems. And in some situations, it can be not suitable to provide patient information leaflet. For example, a patient in second stage of labor, and there is fetal distress. You are telling her about instrumental delivery. Is it logic to give her patient information leaflet to read? Of course not. So please, because this happens, some doctors, they have a sentence that they say in all situations. I will give you patient information leaflet. It's not logic in some cases. In some situations, it's not logic. For example, rare diseases and also in difficult situations, like in emergencies. Acknowledge personal clinical limits and seek senior support. It's one of the safety points. You are not the consultant. And please, whenever the patient coming and she wants to see the consultant, you have to say, I am sorry, consultant is not available. And already you introduce yourself from the beginning. And if she's accepting that you can continue consultation or not. Of course, she will continue. But you have to acknowledge that you are not the consultant. Awareness and adherence to clinical governance. Like what? Like instant report whenever needed. Investigations to be done whenever needed. Okay. So any question about patient safety? You may open your mic now if you want. Okay. Next domain. Communication. And the communication including communication with patients and communication with colleagues. Communication with patients in simulated patient task and communication with colleagues in simulated colleague task and also in simulated patient task. because you are not working alone. Some cases will need team of experts, and please don't make the word team of experts as a routine word in every station. Not all cases need team of experts. For example, candidiasis, syphilis. Okay, not all situations need team of experts. If needed, say it. If not needed, don't say it. For example, vaginal candidiasis. Why to involve team of experts? If you can treat, okay. If you cannot, refer to gum clinic. But there is no need for team of experts. Okay. So communication, your English, very important to be simple and easily understood. Introduce yourself. It's infrequent now that we find a colleague or a candidate starting the station without saying the name and saying the title. Usually now they do. But whenever we start the course, you'll find at the beginning some candidates may go to the topic directly. But with training, of course, it will be your personal attitude that you start by introducing yourself first. And even you can start to be trained now, even in your private clinic or in public hospital, more logic in public hospital, to introduce yourself first. Say your name and what is your title, what is your job. Build rapport and create supportive environment. Build rapport. For example, when you introduce yourself and ask the patient about her name and her age, and you say, I know that you are here because of so and so, you are now establishing good rapport, establishing relationship. Okay, not I am Dr. Osama, and unfortunately the scan showed the baby is dead. It's not good attitude. Okay, take it gradual, start gradual. Active listening, very important. Notice, the role player is here to help you, especially if you are a competent candidate. Role players are very happy to help candidates, especially competent one. Okay, that's why everything the patient will say to you, it's important. The role player is taking you towards success. Use empathetic support. We spoke about empathy. Provide support, time, space, particularly during contractions. Very important. Whenever the patient cannot speak and cannot listen, wait. Let's make a pause. Take a silent moment. For example, during contractions or whenever the patient is crying. Non-judgmental approach. For example, a patient coming and she had IOPD and investigations showing that there was placental abruption and she is cocaine abuser. Doctor, cocaine killed my baby? Yes, thank you. I will go and commit suicide. I killed my baby. I will kill myself. Be non-judgmental. Another example, obesity. Okay, a patient has BMI 42 and she had DVT. Yes, you had DVT because you are obese. MashaAllah. So be careful. Be non-judgmental. And some can you can say you are very obese. Oops. Morbidly obese. Be non-judgmental. Recognize and respond sensitively to the patient concerns. We are in the clinic to address the patient concerns. We are working as doctors to address patient concerns. So they are very important. Respect the patient autonomy. Offer reassurance that is appropriate, balanced, and proportionate. Last domain, applied knowledge. Because communication involving communication with patients and the communication with colleagues. Thorough evidence-based clinical understanding. Interpret clinical findings. Justify what investigations needed. Justify, not say what investigations needed. You will justify. You will say we need full blood count to see if there is anemia. We need X-ray to see so and so. We need ultrasound to look at the ovaries or look at your womb. We need MRI to know more about the mass. You have to justify. The patient is not a tool. The patient wants to understand why you are asking these investigations. Because, in everything, there will be waiting lists. Okay, she will stay some time until finishing and doing these investigations like imaging. So the patient should know why you are asking for it. Okay, and here comes a challenge. For example, don't say beta HCG, say pregnancy hormone. Don't say I need Doppler ultrasound. Doppler ultrasound, it's difficult how the patient can understand it. The patient doesn't know what is Doppler. So say, we need a scan to show how the blood going to the baby. It's now easier. Okay, don't say we will do ALT and AST. No, say we will do some blood tests to see how your liver works. Don't say serum creat. Okay, say we will do blood tests to see how your kidney works. So now we say it as simplified, and at the same moment, we said what is the target of the investigation. So the patient should know what is the target of the investigation. So again, we have 14 stations, 9 of them simulated, either simulated with candidate as role player, simulated colleague task or simulated patient task. And 5 structured discussion, you and the examiner only. 5 lay examiners in the simulated tasks. Every station 12 minutes. In every station, you are assessed in 4 of the 5 domains. What are the 5 domains? Communication with patients, colleagues. Now to domains. Safety, third one. Information gathering, fourth one. Applied knowledge, fifth one. 1, 2, 3, 4, 5. In every station, 4 will be involved. And already it's present clearly in the question that this station assessing the domains 1, 2, 3, 4, they are written. And these domains, they are the key to your success. So you have to think in this station, what is important here in communication? What is important in safety? What is important in knowledge and so on? Okay, because whenever you enter inside the cubicle, 1, 2, 3, 4, these are the 4 domains. At the first moment you enter in the cubicle, your score now is fail in every one of these domains. You didn't speak yet. Whenever you start to speak, okay, you will start to move from fail to borderline and from borderline to pass. This is our target, to take pass in every domain. Pass, pass, pass. Because pass in every domain, it means you took 2 out of 2. Because fail means 0 out of 2. Borderline means 1 out of 2. And pass means 2 out of 2. Because total 8 out of 8. Our target, we need to collect as many as possible marks in every station. Ideal is if you get 2 in every domain. So you get 8 out of 8 total. And if there is lay examiner, there will be additional 6 marks present with the lay examiner. Okay? Okay. And there is also global mark. That at the end of the marking sheet with the examiner, we need to give a global mark. Okay, global mark for this candidate, pass or borderline or fail. Okay, it's a global assessment. Because some candidates are very clever, but time was not enough. For example, a role player who was speaking too much, wasted some time, but we believe he is a competent candidate. Okay, we can give him pulse. Okay. These 14 stations, they are assessing 15 core knowledge areas. And in every station, we have 4 out of 5 domains. 4 out of 5. Doctor, here they are 4, but communication including 2 domains, with patient and with colleagues. These are the knowledge areas: clinical skills, teaching, core surgical, post-operative, antenatal, maternal medicine, labor, delivery, postpartum, gynae problems, subfertility, sexual and reproductive, early pregnancy, gynae oncology, urogynae. So every station will take at least one of these core knowledge areas. It's very important while preparing for this exam to study patient information leaflets. They are present on the MRCOG website. You should study all of them. They are very easy, simple, and they will guide you how to use the lay language. From here, from Browse All Patient Information Leaflet, you will need to download everyone here one by one. Open it and download. They are very simple, very easy. For example, hysterectomy. And even now they made a video about some of them, and even they made podcast about some of them. So here's the video. And here you can read it. And there is even infograph. For example, here recovery after hysterectomy. And here it was updated in 27th of June. So you need to study every one of these patient information leaflets. Very important. For example, here, womb. So you will say womb rather than uterus, because we don't want to use jargons. Jargons mean difficult medical terms. We need to use simple lay language, so the patient can understand as well. Okay. Okay. So any questions so far? You may open your mic to ask. So you witnessed a scenario of shoulder dystocia in the department, but you were not fully aware about what they are doing. Many people were present. It was an emergency, some techniques were done, but you are not fully aware about what they did. Okay, so Amr will be the candidate. He will meet you at the beginning, introduce each other, and he will start to speak about shoulder dystocia. He will ask, I know that you are here to discuss about shoulder dystocia. Can I know why? Why this topic specifically? What do you know about shoulder dystocia? And they will continue the conversation together, and we will need to cover these domains: communication with colleague, information gathering, patient safety, applied knowledge. Other doctors, okay, will take the role of examiners. I need every one of you to assess history, information gathering, communication with colleague, safety, and knowledge. Are you ready?
Okay. So I'm supposed I don't know Dr. Nahla, right? I should introduce myself
Yes.
every time.
Y-
Okay.
Yes. So,
Uh,
but you can start the meeting with, "Hi, Nahla. My name is so and so. I am Amr ST5."
okay.
Okay. Okay. I will adjust the clock only to 9 minutes. In the exam, of course, it will be 10 minutes, but here always in the course, we adjust to 9 minutes only because I need you to finish fast. Okay, you can start. And
Okay.
don't worry, I understand that now you are assuming the performance of intermediate candidate. So understand. So you
Okay.
can start.
Good morning, Dr. Nahla and Dr. Amr. How are you?
Hi, I am fine.
How can I help you today?
I want you to inform me about shoulder dystocia.
Okay, shoulder dystocia is uh, an emergency during labor where the baby's shoulder is impacted behind the pubic bone. And what specific area or topics you want to discuss it?
Yesterday, when we are in the labor room, there is one patient delivered, and after head coming, the shoulder was stuck, and I did. They do many maneuvers. This is first time for me to attend this, so I want to know more about this.
Okay, first of all, when shoulder dystocia happens, it's very important to call help from everybody, from senior obstetrician to senior anesthetist and midwife to assist you for maneuvers. And because it's emergency, we need to deliver the baby's shoulder in less than 4 minutes. Otherwise, will be permanent cerebral damage due to lack of oxygen. So we need to perform maneuvers. There is multiple maneuvers we can perform so we can relieve the impaction as soon as possible before any damage happen. After calling help, we'll start with the first maneuver, which is McRobert maneuver, and which is flexing the side of the patient towards their abdomen, accompanied with some suprapubic pressure to dislodge the impacted shoulder. If this is the most successful maneuver, but if this maneuver didn't work, we can switch to other maneuvers quickly as possible, like delivering the posterior shoulder first, some maneuvers like rotating the anterior shoulder. Uh, do you need any expansion on this?
Yes. Now you tell me about two maneuver, macrobert
Yes,
and posterior. Yes.
and level posterior. So sometimes we try to rotate what we call cock and screw maneuver, which rotates the anterior shoulder, pressing over the posterior aspect of the anterior shoulder to rotate it so we can deliver it. If this doesn't happen, doesn't succeed, we turn to the other maneuver like all-in-four maneuvers. We tell the patient to assume the position on her forelimbs, so we can relieve the posterior shoulder first. Uh, there is some surgical also maneuver we can do if this all failed. We can repeat it. This surgical maneuver like symphysiotomy or cordiotomy, which breaking the clavicle of the baby, but this is the last option for us.
Okay.
Do you need any expand on?
And after that, if the baby is was delivered, what we do after that?
Of course, we need to senior neonatologist to be present during delivery. He must examine the patient and maybe perform some emergency resuscitation if there is too much time used in maneuvers. Uh, that's it.
And I know that after delivery, maybe patient, uh, I saw the doctor. He examined the patient to assess if there is any tear. And
Uh, of course, we need to assess the mother for any tears of SIB because there is a high risk of third and fourth penile tear. We need to assess the episiotomy if one has been applied. We need to assess the cervix of the woman. and continue with our third stage of management of labor.
Okay.
So, Amr, can we predict shoulder dystocia?
It's very hard to predict social dystocia, but are risk factors. For example, if the mother had previous shoulder dystocia before in the previous delivery, if the baby is large, macrosomic, of the patient have like recent surgery in his pelvis or rickets disease. But this is just risk factor, but we cannot predict for sure if shoulder dystocia will happen.
Okay, so with this shoulder dystocia, any other complications may happen? Should we anticipate something else?
We can perineal third or fourth perineal tears. We can anticipate postpartum hemorrhage. For the baby, we can anticipate any trauma, either to the brachial plexus or trauma to the hand itself while pressing over posterior shoulder. And of course, if the maneuver takes more than 4 minutes, we need to resuscitate the baby as soon as possible and assess her if there is any cerebral damage.
Okay, that's great. Any documentation I need to do?
Of course, we need to write an incident report, and we need to specify which shoulder was the anterior shoulder during delivery and which one is the posterior shoulder. That's it.
And sometimes a mom
Also,
asks, yes, here you are, Nahla. Here you are.
yes, and for this patient, for future pregnancy, she can deliver normal or by CS, what I told for this patient.
I'm sorry, can you repeat the question?
For the patient, for next pregnancy, she can deliver normal or she can deliver by CS, or this shoulder dystocia can recur.
Well, there's a chance of recurrence, but she can go for normal delivery unless the baby is severely damaged or severely injured. Then we can offer her the option of cesarean section.
This means that we can prevent shoulder dystocia in the next deliveries.
We can, of course, we can anticipate higher risk of shoulder dystocia in next delivery. Yes.
Okay, thank you so much, Dr. Amr. Thank you, Nahla.
Thank you.
Thank you.
So, well done. Very good. Excellent, Amr. So, from other doctors, can you give us feedback? Raja, Millie, Rasha, Sarah, Soler, can you give feedback? Okay, anything you liked? Anything Amr can improve? Millie wrote less information gathering. Okay, so Millie, what do you think? How we can improve information gathering here? For example, we can ask Nahla. Nahla, can you tell me more about this patient? So Nahla may say the baby was macrosomic, the woman was diabetic, and so on. Or there was a delay in first or second stage of labor. Also, information gathering can be by asking the candidate, can you tell me what you know about shoulder dystocia? Because the role player herself who is here the colleague, can tell you, yes, I know it's a delay in the delivery of shoulders. So she saved some of your time. Okay, so you don't need to repeat what she knows already. You can continue. Okay, so what else? Actually, knowledge perfect. Okay, he is very aware about the green top guideline and the algorithm of the management of shoulder dystocia. So this is the algorithm. And in some stations like here, that there is mnemonic. We can say there is mnemonic called helper. Helper. Number one, call for help. It's an emergency. So the midwife, whenever she finds that there is delay in the delivery of shoulder, she will ring the buzzer. So we know that there is emergency in one of the rooms. We will run to this room. And the midwife should stop pulling, and also the mom should stop pushing, because it's bone against bone. Pushing will not help. It's not soft tissue problem. And we have to say this sentence clearly. It's not soft tissue problem. It's a bony problem. And the first technique, Mac Robert. It's effective 90%. With Mac Robert, suprapubic pressure, whatever, continuous or jerky. So both of them together. Mac Robert plus suprapubic pressure. If failed, we assess for episiotomy. So we can do internal maneuvers. Whenever you say episiotomy, you have to say anesthesia. Whenever you say oxytocin, you have to say anesthesia and CTG. Whenever you say epidural, you have to say CTG, you have to say assessment. So here assess for episiotomy. And don't forget at the end to close the episiotomy if you did episiotomy. Episiotomy here to help internal maneuvers. Among internal maneuvers, the initial one will be the trial to deliver the posterior arm, not posterior shoulder, posterior arm. If you didn't find the arm, rotate the shoulder. Whatever rotation of the anterior alone, posterior alone, both of them together, it doesn't matter. If failed, inform consultant. And informing consultant here will be counted as communication with colleagues also. Then all four, and repeat again the techniques. If failed, the invasive maneuvers, like the Vanelli, kildotomy, symphysiotomy. Already 90% will respond to Mac Roberts. Some words that can be said also here. Turtleneck sign. 60 seconds. Delay in the delivery of shoulders after the head is delivered. And as Amr said, every second matters. Because already the head is delivered, the baby wants to breathe, the cord can be compressed, the baby may start to suffer. In addition to complications of the shoulder dystocia itself, brachial plexus injury. The good news, 90% of the injuries are reversible. Even if the baby developed herpes palsy, 90% reversible. Risk factors, but it can occur even without risk factors. As Amr said, and this was perfect, it's unpredictable. There are risk factors. We have to respect them, but it's still unpredictable. It can occur even without risk factors. It can occur even with cesarean section. Can occur even with a baby with body weight less than 4 kilograms. But still, there are risk factors. Okay. And whenever we are managing shoulder dystocia, we should be ready for the next complications, like atonic and traumatic postpartum hemorrhage, obstetric anal sphincter injury. And again, don't forget to close the episiotomy if you did episiotomy. And the baby should be assessed by neonatologist. And we should see if there is injury or not. Measures to prevent: if the mother diabetic with baby more than 4.5 kilos, delivery will be by cesarean section. And if the baby developed herpes palsy, next delivery will be by cesarean section. If the baby normal, next delivery can be vaginal. So here future pregnancy, and of course there is a risk of recurrence tenfold. So this is helper mnemonic. H means help, E episiotomy, L legs in Mac Roberts, B pressure, E enter your hand for internal maneuver like delivery of posterior arm or rotation, R remove posterior arm, the other R roll the woman to be all four position. At least say there is mnemonic called helper. Okay, it's a well-known mnemonic. Just say its name even without explanation. Documentation here very important, including documenting which arm and which shoulder was the anterior one. Because in shoulder dystocia, we can do injury and brachial plexus to the anterior, not to the posterior shoulder. Okay, and we have very interesting video from Prombit about shoulder dystocia. Let's see it from YouTube. Okay, it's from Prombit videos, and I advise that every one of you should see all the Prombit videos. It's very useful. Prombit shoulder dystocia.
Shoulder.
Okay, you can hear well the sound.
Delighted to be here today to talk about the prompt shoulder dystocia training. Kathy, one of our research midwives, and I are going to go through the maneuvers today. So to try and illustrate for you how best to manage shoulder dystocia, condition we all know is unpreventable, therefore we just need to be able to manage it as best we can. So Kathy, I wonder if we could get straight on with the maneuvers. One of the things about shoulder dystocia I always think is it's a bony problem, and I always use the analogy of it's like a truck going through a low bridge. So can you imagine the cab of the truck gets through the bridge, but the back of the truck bangs up against the bridge. So can you see the cab is like the baby's head, and can you see the shoulder is stuck behind the pubic symphysis? So it's a bony problem. Just pulling the cab through the bridge is going to damage either the truck or the bridge. So the first thing, Kathy, I wonder if we could try is diagnostic traction. So the key issue here is you need to know there's an impaction. And it's really important, just as Kathy's doing, to pull in the direction of the spine, axial traction.
The word routine axial traction is very important. So Mac Roberts with suprapubic pressure and routine axial traction. What is the meaning of routine axial? It means keeping angle 90 degrees between the head and each shoulder. So not to be tilted to one side, as tilting to one side can damage the brachial plexus.
Now, I think when we were young, people definitely used to pull right down. They used to crouch down to try and pull the truck underneath the bridge. Well, we know now that that's more damaging. So just see, is it coming, yes or no? Okay. The first thing then to do is call for help. You need the team around you. You're going to need a person for each leg from Roberts, and we're definitely going to need someone to do suprapubic pressure as well as the person looking after the baby's head. Now, first thing, call for help. Second thing, let's do McRoberts. So McRoberts, if you can imagine the bridge is tilted slightly forward, then making the bridge vertical makes the arch higher. The woman's the same size, but it just helps you get the shoulders, the truck through the bridge. So Kathy.
So I've pulled Mum down the bed,
Yep.
Okay, and then I'm going to make her flat, and then I'm going to take her legs right back so her thighs are against her abdomen, and that lifts the bottom off the bed, okay? And I'll need somebody both sides so that we're both supporting the legs.
So once the bottom's off the bed, just as Kathy you said, then I think that shows you've got McRoberts in the right position. The second thing is, if you do suprapubic pressure, that presses down on the anterior shoulder. That's it, perfectly. And I think like a CPR
hand.
position. And can you imagine, you need to push down on the truck, not the bridge. So Kathy's now pushing down and across to get the shoulders slightly in the oblique, so down and in the oblique if you can. So if that is unsuccessful, we need to move to internal maneuvers. Just to give you an illustration again using the truck and bridge analogy, can you imagine the bridge is like a heart shape. If you could rotate the shoulders into the 2 o'clock or 10 o'clock, you've got more space to run through the bridge. However, if you can deliver the posterior arm, that's like taking the wheels off the truck. It drops it down 10% and you can run it through the bridge. So Kathy, I wonder if we could kind of attempt those two things.
So if I'm going to do an internal manoeuvre, I need to put my hand scrunched up. We call it the Pringle manoeuvre, so that's as if you were getting the last Pringle out of the carton. And I'm putting my whole hand in at the base, so at 6 o'clock, not leaving my thumb out, I'm putting the whole hand in with the aim that I'm going to find the posterior arm. Babies often come down the birth canal like pharaohs, and so you can grasp that posterior arm and just deliver it straight up, just like you were putting your arm up in class. The idea of that is that the baby's now 1 arm's width narrower, and so that anterior shoulder should drop underneath the pubic arch and you can deliver the baby. Any traction I do would be in an axial direction, so never downwards, but axial as if you're pulling along. And in this instance, we would deliver the baby.
Great. So let's say that delivers a baby for this one, but some babies, the arm is straight and you can't deliver the posterior arm very easily. And I always think, going back to the analogy, imagine the bridge is like a heart shape. Then can you imagine if you could rotate the back of the truck to either 10 o'clock or 2 o'clock, there's more room than there is at 12 o'clock.
Okay, so this time I'm putting my whole hand in again, and I put my hand in at the bottom, and this time I can't feel a posterior arm, and therefore all I can feel is the shoulders. So I'm going to aim to rotate the shoulders. So I will push on the front of the bottom shoulder, and I'll ask an assistant to do suprapubic pressure towards that wall. So as we do that, we're rotating those shoulders into the oblique, and the shoulder is released and comes under the pubic arch.
And it still may be worth trying some diagnostic traction to make sure that's released. Now, those manoeuvres in themselves seem to be effective. Certainly in the last series we published of 17,500 consecutive vaginal births, no further manoeuvres were required. And I think it's important we do the manoeuvres that we know as well as we can do.
This is the RCOG algorithm, which lists all of the manoeuvres that we've just demonstrated here now. You can see that you take step-by-step approach to the manoeuvres. If you get to the bottom and you've found that they haven't worked, it recommends you go back to the start and start with the McRoberts manoeuvre again. So take the legs out and put them back in. It may be appropriate, if the mother's mobile, to put her onto all fours position, because just the movement into all fours may be helpful at releasing the shoulders. We also have documentation, and this is the RCOG pro forma for documenting each manoeuvre, so that it's very clear after the event what actions were taken.
If you'd like to learn more about how prompt training.
And of course, don't forget at the end to debrief the mom and debrief the team, to inform the mom what happened, why everyone was here, and what will be the outcome later, what follow-up will be needed. And to debrief the team about what happened, what the good things we did, and what things even we need to improve. So we can learn from each scenarios. And even you can go to the RCOG e-portfolio and reflect there what happened and what you learned from the situation of shoulder dystocia. So if we look together at the mark sheet, so information gathering or communication at the beginning, it will include support, dealing well with your colleague. Please, when you are speaking to your colleague, all of you are specialized trainee, no need to say doctor. So I am Osama and you Amr and you Nahla. No need to say doctor. If you are speaking to consultant, say Mr. and Miss. Okay, but trainees together, you can call the name without saying doctor. So I am Osama, you Nahla, and you Amr. And asking about what you know about this topic, why you choose this topic, do you have any questions? And it's good even to ask a question to confirm that the colleague understood well what you said. For example, can you tell me one of the risk factors of shoulder dystocia? Excellent, you are a great learner. To support and encourage. Information gathering about previous knowledge, what he knows about this topic, and even information about the situation of shoulder dystocia. Patient safety will come from following the same algorithm of the RCOG and even the follow-up later for both the mom and the baby, and even counseling about next delivery. Knowledge coming from the same algorithm of the RCOG. So here we finished everything for today. And the coming plan is our course, inshallah, will be every Thursday, same timing like today until the exam. In every day, we explain and discuss about 7 to 8 stations, very important ones. And same like what we did now, one doctor will be active and also one will be role player, because you need to feel how role players behave. And this other doctor will feel at the same moment how examiners behave. And the number of active candidates is very limited because already we have 7 stations. So usually one doctor will take one active station every meeting. Other candidates will be listeners. And also there is one-to-one, I think, very, very limited places in one-to-one. So here I can receive your questions. So any question here about anything? Amr, Raja, Mili, Nahla, Rasha, Sarah, Soler, SW, let's say so. Any question here?
Well, I have one question because it's not clear to me about booking the exam. I'm sorry.
Yes,
You told me there is two dates for booking exam, one priority date and another date.
that's right.
Is this priority date, is it open for all candidates or just reserved for UK candidates?
For UK candidates.
For UK, so I am not allowed even to apply or to book in the first date, right?
Yes, you are not. Already the college will send you an email saying if you are a trainee or are eligible to be in the priorities, they will send you an email and giving you the link for payment. Otherwise, you will send another email that you will be in the second wave, and also they will give you link of payment.
Okay, thank you.
Yeah, thank you. Other questions? I think most of you on the WhatsApp group called 3G. If not, please send me a message after the meeting. I will send you even the payment method and how you can subscribe for the course, inshallah. Any question?
Hello, Dr. Osama.
Yes, hello, Raja.
I have submitted the assessment of training before 1 month or more, but they did not
Excellent.
reply to me. I need to send to them again, or what to do, or waiting just.
Yes, wait 1 or 2 weeks, then bog them by sending them an email. They are slow in replying to assessment of training. Okay, they can take up to 1 month and a half.
Okay, thank you.
Thank you.
Okay, doctor, regarding assessment training, I already submitted the assessment training like 2 years ago. It
Perfect.
doesn't matter, right?
Perfect.
Okay,
Finished.
so
You don't need to do it.
in it, okay.
As long as it was approved, you need nothing to be done.
I'm so sorry, doctor. This is my first lecture with you. Is this second lecture or the first lecture?
First, we
This is the
didn't have
first
a
one.
meeting last week. Yes, this is the first one. This is the orientation
This is
session.
the first. Okay, okay, excellent.
Okay, any question? Okay, thank you so much.
I'm sorry,
yes.
just small questions.
Sure.
What should I do if I forget some information? Like For example, if the patient or the role play ask me about some data I have no longer in my mind.
No problem. As we said, the college is saying this is not a knowledge exam. So no problem if you forget something, you need to escape by a smart way. Or you can give an approximate answer. For example, the patient is asking you, Doctor, what is my risk of having shoulder dystocia again? You don't remember the number.
Yes.
Okay, but you can say it's less than 10%. Excellent. That's a good answer. Okay, but don't say it's 6% if you are not sure. 5% if you are not sure. No, less than 10% will be good. And also some smart words like it's around 8%. Around, it's good. It means approximate. I cannot say you are wrong because you said around. So this is a smart reply. But if you don't remember at all, and you cannot say a smart reply, no problem at all to say, it's not up to my mind now. I will check and reply to you in next meeting. No problem. Clear?
Okay.
Okay.
Okay. Thank you.
Thank you. So try smart reply first. If you cannot make it, okay. Let's say it's not up to my mind now. But the worst thing is to say an answer that you are not sure of. Because if you said something wrong, it will be considered against you in the safety. You are fabricating data. You are saying wrong information. Better to say I don't know rather than saying wrong information. Okay? Okay. Thank you so much. Thanks again for attending this meeting, and best wishes for all of you. And I hope you enjoy, because actually studying for part 3 is very interesting. Thank you so much. Best wishes for you all, and salam alaikum. Goodbye. Thank you.
Doctor, I'm sorry.
Yes, here you are.
I am so sorry. Too many questions.
No worries. No worries. Here you are.
We will have one lecture every week, right?
That's right. Every Thursday. Same like today,
The same time, right?
but will be longer.
Okay. Okay.
Yes.
How long?
Okay, about 4 hours. We take 2 hours, then a break, then another 2 hours.
Okay. Okay.
Yep.
So, and how we can access to the previous lectures?
Excellent. Of course, all videos and PowerPoint are present on our platform. So even if you miss a meeting, you have access to the PowerPoint and the video until May exam. All videos and the PowerPoints of the meeting, same like the one of today. So today, we will upload the video of this meeting and the PowerPoint to the platform. Already PowerPoints are present, and already videos of last batch. It's called batch 3G for doctors who had the exam in November. Their videos are present. With every new meeting, we remove the old video and upload the new one. So already from the first moment, you have access to full curriculum.
Okay, thank you, Doctor.
Yeah.
Thank you.
Okay, thank you, Amr. Thank you. So best wishes for you all. And okay, this is the same question, Millie. Yes. If you subscribed and not added to the website yet, please contact me. We will confirm that you have an account on our website and give you access. Okay. So contact me, Millie. We can arrange. Yeah. Thank you. See you later. Best wishes for you all, and salam alaikum. Goodbye. Thank you.